Hello and welcome everyone to the No Normal Show for Thursday, August 13th, 2020, brought to you by Revive Health. This is our weekly deep dive into how hospital and health system marketers can navigate what we're calling the no normal. I'm Chris Bevelo, Health Systems Practice Lead at Revive Health, and your host for the show. I'm joined by Chase Kleckner, who is Senior Marketing Manager at Revive Health and our show's producer. Hello, Chase.
Hey, Chris. Good to see you as always.
Good to see you too. And we are joined once again by Jeff Spear, who's EVP here at Revive Health on our strategy team. Jeff's been working with healthcare companies for nearly 20 years in all manner of engagements, from brand strategy and identity to earned media, and lots of issues in crisis, which makes you a perfect guest for today's show. What's up, Jeff?
How's it going, Chris? Chase, nice to see you again.
Good to see you too, sir. Thank you for joining. This should be a very interesting show. I think this is going to be an interesting topic to dive into. So glad you're with us. Some notes before we dive in. If you're new to the show, what do we mean by the no normal? So obviously, as we all continue to work through COVID-19, we hear people talking about the new normal. When are we going to get back to normal? Our point of view is we have no idea what normal is going to look like, or even when we can start referring to things as normal. So we call it the no normal environment. And in terms of healthcare, it's going to take months, if not years, potentially, for us to get to something resembling normal. That said, that can't stop us from moving forward. We have to learn to live and succeed in this era of uncertainty. So this show is about how can we do that. And it is focused just for you, hospital and health system marketers and communicators navigating the no normal. So if you want to know more about that point of view, check out our blog post on it and the 5 principles of what it takes to succeed in the no normal. Chase will post a link to that in our chat function in Zoom. For our live listeners, if you've got questions for Jeff or myself or Chase, as we move through the show, please put them in the Q&A queue in the Zoom window. You can use chat to talk to other attendees. Chase will be using the chat function to post links that about things we're talking about. But if you want us to address a question in the show, we look for that in the Q&A queue. So make sure you guys put it there. And remember, you can subscribe to the podcast on iTunes or wherever you listen to podcasts. And as always, we post a recording of this show by the end of the day on our website. So you can also go get it there. If you want to see it again or share it with somebody else, that's at thinkrevivehealth.com/COVID-19. Just a couple updates before we dive into the topic for today, which is rogue doctors. But a couple of things I think that will help us lead into it. So the first is, Jeff, you had actually shared this. It's an article in the New York Times, one of their lead stories today about the CDC announcing that the count that we all have, which, you know, we used to go through when we had our other daily podcast, the count every day. And I'm not sure where it's at now. I think it's at 165, 66, 67,000, something in there. That's actually probably low, and that the actual death count is probably in the United States over 200,000, right?
Well, yeah, I think what the CDC, the data that's coming out says that at least 200,000 more people have died than expected, than usual, based on years of data since March. So they say that that's about 60,000 higher than the number of deaths that have been directly linked to coronavirus during that time. It's a really good article in the New York Times. They show the excess deaths by week, by region, and you can of course link that to when certain waves hit certain regions of the United States. And while there may be other things at play, other causes, they've previously run stories showing that, for example, in New York and New Jersey, the number of expected deaths due to heart disease higher during a certain period. So maybe some side effects of the virus, maybe side effects of not seeking treatment. The bottom line is we clearly don't have a handle on the virus, nor do we necessarily have a handle on how many people are actually being impacted by it directly or indirectly.
Yeah, and I think that's important for two reasons. One is just important overall to kind of understand what you just said, but it also kind of sets up our topic for today because um, y- science is imperfect. How we're counting this is imperfect. Um, and we're all kind of look at Johns Hopkins or the New York Times for the official death counts each day and the cumulative, but we know that that's not perfect. But anytime any kind of uncertainty comes forward for data like this, it feeds the beast of misinformation, of politics, of all the different things that are out there, in both ways, right? Whether you believe coronavirus is as bad as it is or worse, or whether you believe it's not as bad as it is at all. And that's really where it kind of leads into the topic for today. And I want to share a LinkedIn post that I saw today. And I think that's okay, right? If somebody posts on LinkedIn, that's
That's
fair to,
public.
yeah. I mean, it's all good, but I don't want to it's not like an email somebody sent me and I'm sharing it publicly. But I do it because I want to give Katie credit. I don't know Katie Everett. She's chief communications officer at Novant Health, but obviously somebody that's in our circle, professionally, in the folks that we work with. And her post today, I thought, was just very, very powerful. And I think it was from today. She might have posted it earlier. The story she quotes is actually from late July. So it's possible this post wasn't put out there today. And I'm seeing it because it came in my feed today. But here's what she said. False information about COVID-19 must be treated as a parallel pandemic. These conspiracy theories and lies actually undermine our efforts to control the violence, especially when we're dealing with denial of its existence, prevalence, or severity. So again, that kind of leads to anytime we hear a story like Jeff mentioned, some people are going to point to it and see, you don't even know what you're talking about. You can't even be
Right.
straight on how many people have died. Credit to Katie, because that's a really strong stance to take. And we encourage that because we believe hospitals and health systems should be taking stance on health information. And because there's controversy, you may have to come down with kind of this kind of language. So we just celebrate that she's willing to do that. But it leads into our topic, which is what do you do if you're a hospital and health system and you have somebody who is out there in a way that is feeding misinformation, as we all believe that to be. So let's define that. Let's break that down a little bit,
Yeah.
because obviously science is not perfect, as we said. We all know that medicine is not an exact science. So of course there's going to be differing opinions. There is on everything. Anything in the medical community, there's differences of opinions, right? So, but that's not what we're talking about. So we're talking about rogue docs. So first of all, let's separate rogue docs from the issue that has been out there since the beginning of caregivers, sometimes clinicians, physicians, others, who are outspoken about what's going on in their hospital or health system in terms of like PPE or safety precautions, right? So
Right.
we had the ED doctor up in Washington who was fired for speaking out publicly in social media about, hey, we don't have enough and all of that. Just here in the Twin Cities this week, there's a story in the Star Tribune about an ED nurse who was fired, who is suing the hospital here, saying he was fired, and that's a symbol of unsafe conditions at the hospital, right? So that's, we'll just put that more kind of in a labor issue, and we have talked about that in the past, and we can come back to that as a topic. What we're talking about here we're going to focus just on physicians, though it could be nurses, could be anybody, right?
Well, scientists, researchers that maybe
Right. Tied to your,
PhDs.
yeah, sorry. Yes, science researchers tied to your system, your hospital, your health system. And the way we're kind of defining is this. A rogue doctor, we'll just use that phrase, is someone who has an extreme health view, one. And what we mean by that is fringe. It's so out there. It's so on the fringe, as to be like, if it's a bell curve, they're on one of the 5% ends, right? And so typically that means they're going to be counter to what you as an institution are saying in a significant degree. But it also takes another component. It's not just having that view, it's sharing that view in an extreme way. Because you can have a doctor who believes that coronavirus isn't real, or that masks don't help, or that hydroxychloroquine is a cure. But if they're just sharing that in the physician's lounge, that's one thing. It's another thing if they're calling press conferences. It's another thing if they're on the steps of the Capitol, right? So it really takes both of those, I think, for this to become a problem, to the degree that health systems and hospitals need to figure out, well, what can we do about it? And that's what this show is going to focus on, right? So let's just kind of let's go through the rogues gallery. Oh, I just came up with that.
Well, I think real quick though on a problem. There's two problems, right? One is there's a problem possibly to your reputation, because if that doctor is out there talking and then they're saying Dr. Smith, a ex-doctor with this organization, that's a reputational issue. Second is a problem possibly in where we started, in feeding what you and your institution believe are misinformation that are endangering people's lives or harming our ability to control the situation as a community, as a state, as a region, as a society.
Potentially liability issue too.
Yeah.
Right.
Yeah.
So yeah, I mean, there's if you have this situation with a rogue doc or rogue caregiver, extreme health view, extreme expression, lots of headaches potentially. And we would love folks to share, if they're comfortable, and you can keep it anonymous, situations that you're dealing with right now. We're going to share a few here. That's the rogues gallery.
The rogue doctor gallery.
The rogue doctor gallery. Just to kind of, I mean, I think everybody gets it, but to set up the conversation about solutions and paths that you can take. But let's start with the OGs, the original rogue docs, which in my mind were those two urgent care doctors down in your neck of the woods, Jeff, right?
Yeah, Southern California.
Yeah, so Jeff's out of Santa Barbara. So I can't remember, was it San Diego?
No,
LA?
I think it was East LA.
Okay, yeah.
Broader LA.
So people probably remember them. They created a video, went viral on Facebook first, 4.3 million views on YouTube back in April. Elon Musk tweeting, boy, these guys are making some good points. We'll post a story about them, but they were basically saying, hey, this is not a big deal. I don't know if they used the word hoax, but they obviously had a bias in that they were trying to keep their practices open.
Right.
So for one, among a lot of other problems.
And I'll just say, I've seen people repost it. And of course, every time it's reposted, these are two MDs saying it.
Yes,
that's two doctors. It's the
problem, right?
Yeah.
I mean, they're licensed doctors, right? So you can't dismiss them as not experts because they're licensed doctors. Right. But that doesn't mean they're experts.
Right.
They may not. And as you read the story we'll post, and or any other, you can see all the different groups and associations that basically said, look, these guys are nuts. Medical associations and stuff, right? Real experts. But again, with that MD label, it gives them a credibility, right? We are all familiar with the Houston doctor, the steps of the Capitol. We won't go into the crazy. I mean, they're crazy, right? I mean, alien DNA is being used. We got the demon sperm. I said I was going to say that one time on the show and only one time. But
it's out there.
Not only is it out there, we had the highest elected official in this land promoting that message. Like that's a whole nother podcast, not our podcast to get into that, right? But that's politics aside. This is the president of the United States sharing this information, right? Among many, many, many others, right? We had a situation, and we won't name it because we try to avoid pouring salt on the wound of the people that we work with and want to help everyday hospitals and health systems. We won't name it, but people can probably figure out if they dig deep enough. Top AMC in this country had a senior scientist from their staff pull together kind of an ad hoc group early on to try to sway the president and his staff that COVID was not a thing, not going to be a problem, don't shut the country down. All of it premised on hypotheses, not data at all, which is, again, these are senior respected experts, clinicians, researchers, but why in the world they're approaching it in a non-scientific way is why it's a problem,
and
right?
Completely faulty modeling.
Yeah, that's right. And then down the line, right? So we've had doctors show up at school board meetings trying to advocate for opening schools, saying masks aren't needed, this is overblown.
Yeah.
Press conferences held on sometimes on the property of hospitals and health systems, on TV, social media, right? I mean, are we missing anything obvious or big?
Well, there was a doctor that was basically refusing to wear a mask on campus. And then also, like you said, large social media following. It's pretty bad sometimes.
It's pretty bad. And obvious, it's not contained just to our world, right? Recently, there's been a lot of stories about a sheriff in Florida who basically says, no, not
Right.
only am I not wearing it, I'm telling my deputies not to wear it. And you're not allowed to wear masks if you come into the sheriff's department. Like, so the bigger problem that Kate was talking about and that we mentioned in the beginning, goes to all aspects of our society, but this is our world. And this is a unique problem for hospitals and health systems. So with all that said, I think, most people get the issue. We don't have to belabor it. Let's start, Jeff, with, what are some of the ways that we can best address this from a communications perspective? And we'll take some other angles as well.
Sure.
Let's start there.
Well, first, I think the main thing is we have to look at this as it's not us against a physician or whoever's out there speaking. It's us and what are we trying to achieve as an organization and what kinds of facts are we trying to put out there and what's our goal with the public, as well as, of course, our reputation. And we've talked a lot, you have on the podcast, about what it means to be a leader and as an organization particularly during these times. So first and foremost, it's what's your obligation to the community and what's your obligation to the organization to be a leader there. And we really do view it as being arbiters of truth. Your organization has some of the best actual experts, theoretically, on the topic. They can follow other experts and really try to distill down the latest evidence and research in ways that the public can understand. And of course, as we've seen a lot of our clients really advising and working with public health officials as well as elected officials as they try to stay close to what's actually happening, since the science does change, as Chris said, and what we learn about this disease changes from the beginning, and the strategies to address it. So it's really difficult when at one point we were saying, hey, don't wear masks, and we're saying, yes, wear masks. If someone's going to use that against you, they're going to use it against you, but you still have a obligation to be out there with the truth. So I guess first and foremost, we say, don't go out there trying to go against a specific physician or counter a physician or scientists, but you do need to be out there to combat some of these claims and really help your communities figure out the right path. And your spokesperson really should be clinician, infectious disease expert, somebody who has that backing. This is not a situation where we believe CEO, COO, head of HR should really be talking as much as let's just talk about the science and the data, and this is what we see.
Yeah, all that's great. And of course, we're talking about this kind of in the frame of what's happened to this point, right? So that's either to what extent is COVID-19 really a threat? What are the ways to address it? What has the impact been? We talked about deaths and all of that. What you're starting to see now is conversations around vaccines. So something that's coming. And, if this has been an issue to this point, we all know what's going to happen as we start to move into that phase. It's already happening. We already know about the controversy with anti-vaccine vaccine points of view. And so we can imagine as that moves forward, it's just going to be the same, same extreme views, extreme expression with a
Right.
different related topic. And so we got to manage what's happening now, but we ought to be thinking about this in terms of what are we going to do when that starts coming forward?
Well, I think we talked about this a little bit in the last time I was probably on the podcast. The vaccine, whether they're effective or not, whether it's safe or not, and then who gets it.
Mm-hmm.
And what's your point of view as a health system? You're probably going to follow, theoretically, whatever guidelines are put out there by CDC or whoever else, but you still need to have your own view and need to vet that. And I think that's one of the biggest problems here. So hospitals and health systems, I think it's not just, there's two issues, I guess, and you defined it earlier. There's the extreme views, and then the rogue doctors who are out there frequently in a very public way pushing their extreme views. That's the combination. Well, we have to combat that with similar things, which is extreme views on the facts and making sure we're staying update to that constantly and taking a pulse on what people are thinking about now. And I'll give an example in a second, but also communicating about it frequently, even when you're tired about communicating about it. So yesterday, my wife, who's a teacher, asked me, she said, okay, kind of like, where's your view on this? Would you force a 3-year-old with autism to wear a mask on a plane? Because apparently I think she was reading about this maybe with Southwest. And I said, I don't know. I said, I think the latest thing I've heard is that 3-year-olds and people under the age of 4 or so are less likely to have the condition or spread it. And I think the most laws right now that are mandating masks are a little bit older than that. But I don't know. When's the last time I read about it? Probably a few weeks ago. And maybe since then there's new data, because there's new data all the time. So as a health system, you, I think, really need to make sure someone on your team is staying on top of the latest research and informing those people that are leading whatever guidelines you're giving and communicating about to the public. But certainly also you probably need someplace publicly very clear how you're coming to your viewpoints and where your sources of truth are and why those are your sources of truth, and that you're updating those as it changes so that you are not burned later if some data changes.
Yeah, that's great. It is such a it's such a lost point in all of the conversations and controversies that this changes. We learn, we get more data. So you gave it the example of like, don't wear masks, and now you should wear masks. And even that is like, initially the message, I guess there was messages that said, don't wear masks because they're not effective. But the main message, like I can still hear Dr. Fauci,
Right.
was not that they're not effective. It was, well, look, we got to be careful because we got to save these masks for the frontline
Right.
workers. And so that was the main reason not to wear masks, because they didn't want people going out and hoarding masks. But still, it's taken in as don't wear masks, and now it is wear masks. And I saw something recently that said, look, 6 feet is really not the optimal distance. It should be 10. As soon as that stuff gets out there, it's not I haven't heard that from official levels. It was just some study. But that stuff is constant. And so it is the sources of truth that you pick. It is the CDC, if that's who it is. It should be. It's your own clinicians. It's your own experts.
Mm-hmm.
You really have to make sure that that's clear, because there is just everything under the sun is out there and people have access to it.
And they're doing more research. So the mask, I think, even when it evolved, it protects people from you, not necessarily you from other people. But I think 2 weeks ago, I read some studies that actually it does protect you and other people.
Right.
But I guess let's like continue down the path. If you've got a doctor or a rogue doctor out there, are there legal options?
Yeah.
So we did, this is a huge headache for a system, particularly if the physician is not backing down and maybe is on the steps of the Capitol, raging, or leading a very public campaign, or maybe involved in some strange documentary out there. Who knows about it's a hoax from the Democratic Party. So that's a real risk. And as Chris said earlier, potential legal risk. So we did speak with Dan Higgins. He's a partner at Denton's. We work with them, the world's largest law firm, to figure out what kind of options might be out there to address physicians that are maybe putting out what we would call misinformation.
Right.
And what we would say, first of all, is we are not legal experts. So whatever you hear us about to say, and Dan is not talking to you, please talk to your own legal counsel before you do anything. But he did say that they're really, the options are limited for recourse because of physician rights to share their medical opinion with patients and the public. even when, for example, they might be not wearing a mask when you're requiring it on campus. That might be an issue as well. But if there is a significant conversation around an affiliated physician, you can, of course, as we said earlier, counter it with your own point of view. This shouldn't be about the physician. It's just about putting out our facts and hopefully, and I would say do a lot of good briefing with the local media, use your own channels, let people compare these two things together. So get your comms teams involved, as well as probably some people from legal. If the physician is using a logo or the platform of the health system without permission, we of course can ask the physician not to use that, and that's probably in your employment guidelines. Or if it's a non-employed physician, maybe there may be some medical staff bylaws that you can talk through, and put that out there. When it is an employee physician involved, you might be able to do other things. For example, drafting some policy if you don't have it right now on how people can stay safe and our points of view, and then really making it clear who can speak out on behalf of the system and using your logo and affiliation there as it relates to these things, because most of us have some policies around who can speak publicly and needing to be authorized. So it's a good time to put that reminder out there with the context of safe and valid information, not about suppressing someone's voice. It is a confusing time and there's enough things out there. So it's a dicey situation, but the main thing is you've got to be active. You got to stay on top of this. And if you haven't already dedicated somebody on your team to be watching the news, tracking it, course correcting, and really on pretty regular basis with your kind of staying alongside your key spokespeople, making sure they're up to date, similar you would do in any kind of, say, political campaign. You really need to set that time aside and that structure aside.
Yeah. Yeah. And there's just, we just have to kind of think through the way that this can kind of domino, right? So obviously we keep saying this isn't about going after the rogue doctor. Right. And one of the reasons we say that is because you can make the problem worse if a rogue doctor, so extreme views, extreme expression, that doctor's not going to be shy about saying, "Oh, now I got the man coming down. I got these people telling me," like they can drag you into it more than they had in the outset, if at all, right? So there's always a risk of exacerbating the situation. The other way, and we've seen this a little bit. We're talking about rogue doctors and extreme views related to COVID-19. But often that's just one dimension of a rogue doctor's extreme views. And we have seen, not coincidentally, I think is fair, dig a little deep and you see rogue views on other things, particularly when we're in an era of a lot of conversation and unrest around social justice, as an example. So you could have a whole nother conversation about rogue doctors in that area, right?
Yeah.
Outspoken doctors in terms of Black Lives Matter, we'll say. But even if we're not going there, looking at where those doctors are in terms of COVID often leads you through their channels, through other things you may not be aware of, to that. And the last thing you want to do is help draw those, connect those dots for people if you don't want those dots connected. So all of those things kind of, as soon as you dig and kind of peel back the layers, there's a lot more to it, which is why the more you can just kind of stay up here and not get down in the mud, I guess is a good way to say it, the better.
Yeah, it's really interesting you say that you bring this up, Chris, because if this is just a great example of the evolution, I think, that we're seeing of even hospitals in becoming a leader and needing to be a leader. So our studies have shown that the public is absolutely looking at hospitals and health systems for information. They trust hospitals and health systems. They're going to seek information more often. But some of these things that you're talking about around doctors and looking through their backgrounds and some of their maybe very extreme views on topics isn't probably new to anyone who's been in hospital marketing for a while, right? Like it pops up once a year, I would say, where we've got a client that says, hey, I need you to look at this. We found this on social media, or somebody complained about this doctor saying this and that, and it's kind of blows your mind for a minute. And so you go through, well, what can we do? And as I said earlier, legally, there's not a whole lot you can do, but there are staff bylaws and things that come up. So physicians aren't necessarily, it's hard to kick them off a medical staff, but I think there are relatively straightforward ways that you can keep them from renewing. But what it goes to now, I think, is hospitals and health systems have typically not taken very public stances on a lot of things. Now is, for most of our clients, I think, and people, listeners out there, is the time to think about what your stance is and how proactive you want to be. We had a whole show on this, I think, a couple weeks ago. And if you haven't had these discussions with your leadership in what it means to be a leader in your community and how to act on that and proactively look at all the stances that you may or may not want to take and your rationale and why, you really need to get prepared so you're not bombarded every single time by figuring out what to do. Because this isn't going away. Doctors are going to have extreme views. The country's having more extreme divisiveness. So wherever you stand as a system, you just have to know where that is and have a plan on how to speak about it and address it if it comes up, because it's going to come up. And you just can't avoid it at this point, particularly in the next 5-6 months, where if we thought the last 3 or 4 months were crazy, I think we can talk about the vaccine. When schools get back to normal, is the vaccine safe? Who should get the vaccine?
Heat of the election, which is just like fueling so much of this.
Should youth sports happen in your community? I mean, right now we're talking college football, right? Yeah, flu season, but college football is probably canceled. What's your view on that, health system, because you're a medical expert?
Yeah. It just, all of that just brings me back to Katie Everett's post on LinkedIn. And it makes me think of like the degrees of leadership just in COVID information, right? I don't think there's any hospital or health system that's not trying to put out information about COVID, right? So you're like, wash your hands. This is how you get a test. But in some ways, that's leadership, but it's a bit of a minimal version of leadership, right? The next kind of degree would be, hey, it's really important that you find the right, like you proactively talk about the idea that there is alternative information and you really need to be smart about this. Here's what it is, right? So that's kind of the next step. I think even what Katie's doing is a further step of leadership, which is going after the false information. That's why, to me, there's more courage involved in what she's saying. It's a higher level of leadership. There's some risk in it, because obviously you're out there talking about it in a way that some people may say, "Hey, that's not a conspiracy theory. Demon sperm's a real thing." Twice. I'm done. But look, that's what leadership's about. Leadership is rarely where you make everybody happy. Leadership's about taking a stand. And Katie's taken a stand. And that's why I applaud. I think we all applaud that. And there's the opportunity to go that far. And I think for health systems to think about how they want to do that with COVID-19 or other issues, I think is a really important conversation that they need to have.
It is. And taking a stand versus, I guess, having a statement ready if someone asks you, or putting out some cursory things. You posted, I think you share with our company, I think it was you, Facebook said that it took down 7 million posts pushing COVID-19 misinformation between April and June. So that's 7 million they took down, but we know there's many more that are up. So if you as an organization, as a system, believe in trying to combat this, then you can see what we're all up against here. And that I guess one last comment is, well, how do you do it? Because we've talked a lot about not going against the doctor, but we were talking to a client recently about masks and talking about masks in an area of the country maybe it's a little controversial. And they had different approaches they were considering. And I'll say that while you want to be engaging and compelling with public health information that isn't always exciting, I do think it's really important that we get out there as arbiters of truth and be careful on the shaming or political nature that you might want to go to. You might want to compel people by guilt, but that people are looking to us as objective sources of information. So you still need to do it in a strong way, in an interesting way, use creativity, but just remember who you stand for and where your information comes from, and avoid the temptation at times to maybe go the path that some other entities go, because it does draw eyeballs.
Yeah, and it's pretty much proven that trying to guilt people into changing their mind almost has the opposite effect, right? Like it's almost always boiled down to, well, you believe that either you're ignorant or you're intentionally, ignorant. You're intentionally doing the wrong thing. And that may be true for some people, but a lot of people would take that as like, so you're just saying I'm a jerk. I'm either stupid or I'm a jerk. That's not going to get you anywhere. Even if it's true, it's not going to get you anywhere. And it's not always true. Most of the time it's not. Most of the time there is nuance. There is coming from their perspective. There may be all kinds of reasons. It's not because of ignorance or that they're a jerk. But because of the partisanship and stuff, it boils down to that. And we can wrap here. It just reminds me, Jeff, like you and I have been around long enough. We were actually alive at the advent of the internet. I don't know.
Yes, we were.
Chase, I'm not going to ask you how old you are when the internet came around. But back in the day, there was a saying that said, "Oh, I found this on the internet. It must be true."
Yeah.
Which was a sarcastic thing followed by a ha, 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 ha. What happened? Like that was early. People got that early. And now we've gone to a place that it's like, oh, no, I found that on the internet. It must be true.
Sophisticated.
Right? It's real. I found it. It's right there. Like, I don't know what happened, but in the beginning, people got that. People got like, oh, you can't trust what's on there. It could come from anywhere. And now
it's the reverse bell curve. We did do a good job of, I think, sorting through information for a while, but politics and sophistication of the way people convey information, the lack of, I think, recognition of opinion versus fact, or not even caring, just trust. There's so much information, people just go to what they want. My wife, she taught middle schoolers for a while and had a course on trying to find misinformation and how you identify it and fact versus opinion. Maybe we need to bring that back for all of America.
Should be a class for everybody. Yeah, I think it's too late. The genie, she's out of the bottle. Just dump her back in. All right, let's wrap right there. I think that's a good place. Jeff, thanks so much for being our legal expert.
Not a legal expert.
Yes, again, we're not legal experts. We wanted to have the folks from Denton on. They couldn't join us, but they give us a lot of good stuff. So maybe we can have them back on at a later time. But again, Jeff, thanks.
Great to be here. Thanks, Chris. Thanks, Chase.
Chase, sir, again, thank you.
Absolutely. Enjoyed it.
I don't even know who we have next week, but I'm sure it's going to be awesome. Do you know, Chase? I should know, and I don't.
You got me on the spot now. Oh, it's Mark Fredson.
Oh, awesome.
From UCSF. Yeah.
So Mark Fredson's a senior marketer at UCSF, and I like to say the first hospital marketer I ever worked with.
Whoa.
2000. Sorry, Mark. It was the year 2000, the first hospital I ever worked with in marketing, and Mark was on that team.
Right around when the internet came out.
Just right
around. That's what I was about to say.
That's right. Way back then.
They were faxing each other.
If it wasn't for Mark, I would not be sitting here, because if it wasn't for the work we did with them, I would have been so attracted to hospital marketing and made it the focus of my business, and the rest is history. And I wouldn't be here. Who knows what I'd be doing? I don't know.
All owe a debt of gratitude to Mark.
We do. No, that's the opposite. Anyway, so he's coming next week.
Awesome.
If you have a topic that you want us to talk about, let us know. Throw it in the chat channel. You can email us at nonormal@thinkrevivehealth.com. Remember to go to our website, thinkrevivehealth.com/COVID-19 by the end of today for a recording of this episode and all kinds of other content we got there, blog posts, reports, research, you name it. We continue to follow and put out all kinds of content on this. So make sure you check that out. Subscribe at iTunes. And until Mark joins us next week, good luck out there in the no normal. Thanks for joining.